Thank you everyone so much for joining us tonight for this Healthy Women Community Talk, Navigating Your Fertility Journey, presented by the UW-Madison Department of Obstetrics and Gynecology. I'm Jackie Askins. I'm the Communications Manager for our department, and I will be moderating our incredible panel this evening. We will have about an hour of prepared panel questions, and then hopefully about half an hour to take you all's questions, and we've had several already submitted by some of you who registered. If you have questions that come up throughout the event, please submit them using the Q&A function at the bottom of your Zoom screen. You should see a Q&A, two sort of little chat boxes next to each other. If you can submit your questions there for our panel, our team will be moderating that throughout the event. We just want to make sure that we can get your questions to our awesome panelists this evening. I'd also like to quickly introduce a couple other staff who are joining us on this call. Outreach Program Manager Melody Bachenfeld will be adding some links and resources to the chat, and Outreach Specialist Cheryl Casey Grant is here to help with any technical questions. So you can chat with us if you have anything that comes up, if you need any assistance. Our program this evening is being recorded, and the video will be available for you to watch later this week. Watch again, share with friends, whatever you need to do. Also, we're going to share a ton of resources and a ton of information tonight. And all of the links, any resources that get mentioned, we're pulling them together. We'll put them in an email. We'll send them out to you all after the talk is over. So no pressure to take great notes or try and keep up with all the different resources that our great panelists are going to mention. We will pull all those things together and send them out to you after tonight's talk. So, with all that housekeeping, I am really excited to introduce our amazing expert panel of patients and doctors who are joining us tonight for this Healthy Women Community Talk. Stacy Teagarden holds her master's degree in rehabilitation psychology and works with county behavioral health programs implementing evidence-based practices. She finds value in community and has a passion for increasing happiness in the world by helping people find their purpose. Stacy and her husband worked for over a decade to create a family and now are lucky to be the parents of 2 happy and healthy toddlers. Our second patient panelist this evening is Jamie Haynes. Jamie is a mother of 2 who struggled with infertility for years and underwent multiple surgeries, IUIs, and rounds of IVF. Jamie finally found success in creating her family by using an egg donor and ERA testing to transfer embryos at the right time. Our healthcare panelists this evening are Dr. Bala Bhagavath. Dr. Bhagavath is a professor in the Department of Ob-Gyn and director of our Division of Reproductive Endocrinology and Infertility. Before he came to Madison in 2020, he was faculty at the University of Rochester in New York and Brown University in Rhode Island. In addition to his expertise in managing infertility, Dr. Bhagavath is a nationally recognized reproductive surgeon with a special interest in minimally invasive surgery. And Dr. Julianne Zweifel. She is a clinical psychologist who's been a member of the Department of OB-GYN since 2005. She is an integral part of the Generations Fertility Care team with extensive experience providing support for individuals and couples who are experiencing fertility challenges, as well as pregnancy loss and high-risk pregnancy. That was a whirlwind, but thank you so much to all 4 of our incredible panelists for joining us tonight and sharing their expertise. I want to open with a question for Jamie and Stacy, our 2 patient panelists. And we want to start with what motivates you to share your experiences with infertility in a venue like this. We'll maybe start with Stacy.
All right, thanks, Jackie. So as she said, I'm Stacy. I didn't include in my bio that I did go through a few rounds of IUI and finally settled on IVF. We did use my eggs and my husband's sperm and it worked, and we have 3 more frozen embryos, so yay. But all that process was a process, and it was very frustrating, and it was very disappointing for month after month before we even went to make the decision of going through some fertility treatment. So I think just sharing my experience, what motivates me to share this experience is really hearing it from others helped me. So I think knowing, just that I wasn't alone, knowing I wasn't going crazy, my whole life was surrounded around this, and it just felt like it was all consuming, but talking to other people normalized it, that this is a human feeling, and I wasn't alone.
Jamie?
Sure. Yeah. So I'm similar to Stacy. My main motivation is to, help others not feel alone. So we started trying to have a family when we were in our mid upper 20s, so 27, 28. So infertility was not in my thought at all, being younger. So when we were going through this, everyone else in our world was getting pregnant easily, our peer set. So struggling at that age, it was really important for me to find a community. So I found some online communities, some local friends, and they were really my rocks through it. It took over 3 years to get our first child. And as you mentioned in my bio, we had to use an egg donor. So we made that decision at 29, which is also not common. So I love to, share our story to raise awareness and also help people, not feel alone, and to kind of destigmatize these other paths that people take. So yeah, I'm kind of an open book. It's been a long road. The second baby that I'm blessed with also took years. So, I kind of had the primary and secondary infertility, I guess just totally infertile. So, happy to answer questions and be here for anyone that needs support.
Thank you both so much for being here with us tonight. Our next, question is for our healthcare provider panelists, Dr. Bhagavath, Dr. Zweifel. As healthcare practitioners, why is this work so important for both of you? We'll start with Dr. Bhagavath.
I was 12 when I decided to become an infertility physician, because that was when the first IVF baby was made in this world, and it was a world-changing news. And I haven't regretted a minute of that decision. So it's been a long journey to get to where I am, especially since I come from a rural part of India. But nevertheless, through that difficult journey, I have found it extremely satisfying, and not a day goes by when I go home satisfied, happy that I've helped somebody. That's the reason I do this day in and day out.
I'll jump in. First of all, now I know when you were born, Bhagavath. I didn't know that before. I was born in 65, so the year before you. I've also wanted to do this for a long time. This is actually what I went to graduate school for. This is what I studied. So I'm a clinical psychologist, but with a subspecialty in reproductive health psychology. And so what that means is, my work is looking at how psychology and reproductive physiology work together. And I find it scientifically fascinating, first of all. That's probably what drew me to it in school. But in patient care, boy, it's hard work. I just got to tell you, it's hard work. The issues are real, but I also like hard work. Like I like things that are hard, and I find that patients are super appreciative, and so it's very rewarding. It's important work. Like it's really easy to identify why this is important to do. So it's interesting, it's rewarding, and it's hard.
Thank you. Thank you all so much for your introductions. It's really helpful to know a little bit about why this is important to you. I also think it's helpful as we are jumping into more of the meat of our panel talk this evening to set some common definitions and make sure we're all kind of working from the same dictionary of terms. So we're going to start with a handful of questions for Dr. Bhagavath. And I'll start with, how do we define infertility? When we say that term, what are we really saying?
The inability for a couple to achieve a pregnancy after 1 year of unprotected intercourse is the classic definition for infertility. But that has since over the years changed to define or identify age as an important part of this. So when a woman is greater than 35 years of age, that definition is narrowed down to 6 months or more of trying to achieve a pregnancy. Does that answer your question?
Yeah, perfect. And we also got a question submitted by a user via social media. When should someone seek fertility care as a non-advanced maternal age patient? So it sounds like after 1 year of trying unsuccessfully under age 35.
Absolutely.
Okay, Excellent. Overall, do we have a sense of how common fertility challenges are?
Again, classically, 10% was a number that has been always quoted as the prevalence of infertility. But the latest WHO, in fact, it came out only last Monday, just a week on Monday, shows that it is about 14%, roughly. And that 14% is an average. Again, they define it based on demographics and others, and it can go up to 17%. So anybody interested can look into that, but about 14%, which means that the rate of infertility has gone up in the community. So if you look at it from a different perspective, 1 in 6 couples face infertility as a challenge. So that is huge. I mean, if you walk down your street, 1 out of every 6 houses has this problem. So it is very, very common. Of course, they define this as 18 to 49 years of age. There's an age definition there, but in that age group, 14% or 1 in 5, 1 in 6 have trouble conceiving on their own.
What are some of the most common causes of infertility?
I like to think of the process of fertilization as simple as the egg, the sperm, and a place for them to meet, and then a place for them after they meet to reside. So that would be the egg, the sperm, the fallopian tube where the two of them have to meet. They cannot meet in the uterus because the chemical environment is not conducive, surprisingly. So they have to be in the fallopian tube. And when we do cultures, IVF cultures, we mimic that. It is very specific. And then the embryo that is formed takes about 5 days to travel backwards from the tube into the uterus to implant inside the uterus. So that's what it takes to achieve a pregnancy. If you really look into the mechanics of how this happens, the molecular level, it is indeed a miracle that we are all here at all. So many things can potentially go wrong and seem to go wrong as well. And that's why we have this as a specialty. Did I answer that question?
I think I might have some follow-ups of
Please.
So I guess what I took away from that was there's sort of we have a sperm, an egg, and a place for them to meet. Does that mean any number of variances for any of those important pieces or moments could mean challenges?
Sure. So if you want actual causes, there are so many umpteen number of causes. So the first thing I would say, just to be faithful to the history of IVF and infertility treatment, is the fallopian tube being blocked. If the fallopian tube is blocked, then the sperm and the egg cannot meet, and that's why IVF was, invented or designed in the first place. But today we use IVF, and IVF, of course, is not the only treatment. But I showcase that because that is obviously something that everybody thinks about when they speak of treatment for IVF. It is problems with releasing the eggs. It could be something as simple as a endocrine problem, as in PCOS. It could be ovarian failure due to chemotherapy, where patients had to have chemotherapy for cancer treatment. It could be any number of reasons that affect the ovary and therefore prevent the egg from being released. And the same thing goes for the sperm as well. It could be an inherent problem in the testicular formation that results in absence of sperm, or the hormones that are needed from the brain to act upon the testes to create or manufacture sperm. So that could be a problem as well. And of course, men can be affected by chemotherapy, they can be affected by surgery, trauma, any number of things that can result in either poor quality sperm in terms of motility or or the shape or absence of sperm itself. There could also be genetic problems both in the men and women that can affect the production of sperm or the egg. So there are any number of causes that can decrease or completely stop the production of egg. And Jamie, at 29, clearly had a problem with that at a very young age. Most women have at an older age group. So again, it could be any number of these things that can cause that. With respect to the fallopian tube, classically infections block up the tubes, but today that's less common. And the more common is endometriosis, surgery, either resulting in removal of the tube or the tube being blocked off by adhesions from surgery. For example, appendicitis, you would think it's nothing to do with the uterus and the tube, but a burst appendix can result in blockage because the burst appendix causes infection, scarring, that can block the tube. So that can affect that as well. From the perspective of the cavity of the uterus, it could be fibroids, it could be polyps, it could be adhesions from a DNC in the past, any number of things that can block off the cavity and result in scarring inside the cavity. In addition, women can be born with anomalies in the uterus that can also cause infertility. They could have a double uterus, they could have half the uterus. So any number of developmental anomalies can occur as well. Hopefully this is a much more wider answer that you were looking for.
It is excellent. And we also got a question from Stacy that maybe I'll rephrase a little bit. Is it always possible to find a reason for infertility? Does everyone know what is, are you always able to narrow down to exactly what's going on for folks, or are there some times where we just don't know?
Excellent question. Yes, 10% of couples, we don't find anything wrong. You know, you do all the testing and then you find that there is every test comes back normal. There's no actual reason that we can identify. And there is a diagnostic term for that, not really fantastic. It's called unexplained infertility. In the past, we used to call it idiopathic, but we don't use that term anymore. And when we don't understand something, we just say idiopathic, but today we say unexplained, which is more understandable English.
Thank you. Our next question is for Dr. Zweifel. We've learned about some of the causes of infertility. From your perspective, what are some of the common emotional impacts of an infertility diagnosis? What do you see people experiencing?
So I came up with a list and I thought, wow, this list could just be really long. So this is not an exclusive list. The first thing that came in that I put at the top of my list, just right off the top of my head, was isolation. I think people tend to feel really alone in this, at least at the beginning. There's a sense of, often a sense of embarrassment and not wanting to tell people that you're having this kind of struggle. And as Jamie was mentioning, you know, friends are having kids, and that can also lead you to feeling left out. I think there can be a struggle about whether or not to tell friends and family about the struggle, because it's kind of maybe helpful to get support, but sometimes support is not so helpful. Sometimes people are saying really unhelpful things like, it'll just work out, just go on vacation, you know, go have a glass of wine, just don't stress. And that's not so helpful. There can be feelings of anger, of having led what you feel is a healthy life, made responsible choices, and kind of feeling like you were always told that in life, if you just work hard, things will work out. And now here you are, and it's not working out, and there's not really someone to blame. And it's hard to be angry about something when there's no one to blame, because you kind of have nowhere to put your emotions. And then I also just think about often whoever the partner is, if it's identified that there's one partner who seems to be more causal in the fertility struggle, they can feel badly that this is going on for them as a couple, feeling badly that they may be the cause of the struggle. So there's just a lot. And I would say overall a fear of what if this doesn't work out. So I'm sure that's not an exhaustive list, but we could go on and on about each of those things for quite a while.
Yeah, it's always hard to fully summarize the broad variety of emotional reactions. Everyone's experience is a little different.
Yeah.
And I am curious for Jamie and Stacy, how does what we just heard compare to what you guys experienced?
I can go first. So I was listening to you and I'm thinking, yep, check, yep, check. I mean, I definitely felt every one of those things. And it's hard because there's like also shame in there. And, it's just, I mean, we didn't even talk about the stress of the financial part and then also the physical part too. Like you put all those mental stressors along with financial and physical, and you have pretty much the perfect storm to just having some really rough days. And then it also kind of repeats itself every month or 28 days or whatever to get your hopes up and then have them crushed. So yeah, I mean, it was spot on. I'm trying to think if there's anything that I went through that you didn't say. Probably. I think it's just like some days are okay, some days are not. Anyone that's been on this roller coaster, it's very hard to describe, I think, until you've lived it or until you've worked closely probably with patients that have been through this. But yeah, spot on. That's why I think the infertility community is very tight, maybe kind of anonymous, but like when you connect with other people that go through this, you kind of have an instant bond or friendship because like very few people fully get it until you're in it. So that's like for me, finding that group, in-person group, online group really was important to me because those people got it. I had some friends, some family better than others, understood it more than others. Some really didn't. So yeah, I think finding your tribe and, also I learned a lot from the communities. Like Facebook and the internet can be a bit of a dangerous can of worms, but you can also really learn a lot and connect with people and, learn how to advocate for yourself, learn the type of questions to ask. So yeah, spot on for that assessment on what you go through when you're going through infertility.
Yeah, I agree, Jamie and Jamie and Dr. Zwiffel. All of those things were exactly too. Check, check, check. I was one of those unexplained infertility. The doctor had told me that was pretty common, and we just don't know, and just keep trying to have sex, and it was like really, really frustrating. And so that's why, well, we'll start with the IUIs. We'll start with the these procedures because there's nothing wrong with either one of you. And so that, I think that was more of that frustration of how do you get past I can't blame anyone. Like, what's going on? What is this? Why can't I have an answer? Not only will insurance not pay for treatment for unexplained anything, it's kind of frustrating to know, where do you go from here and how, like, you can get treatment for nothing. So ended up doing the IVF, which was a lot of like, again, decision making. Do we blame each other? Do we just go through this? Do we have the expense? I remember joking that we'll pay him off when he's in kindergarten, and we had like a 5-year loan. So kind of, well, this is just how it is if we want a family, and we just made that decision. But just like Jamie said, not a lot of people were supportive. We were in a boat of friends that partied and just had their time, and just think of it as a blessing. You don't have kids, you don't have to worry about it, and that's not where you're at. So you want to, if you want what you want a family, you don't want to hear that. So moving to that tribe that does support you is what we had to end up doing. And that anonymous thing was helpful because then I didn't feel like I was putting my husband under the bus, even though again it was unexplained for him. People could assume it was him, so I didn't want again, a lot of feelings around that for sure.
You both mentioned, and we will dive into this later, just in case any of our listeners are thinking about it. You both mentioned what wasn't helpful. And so later, I'm really looking forward to learning about what was helpful, what was useful, and any recommendations you have for folks to seek out resources. So we will circle into those a little bit later in the panel. We talked a lot. Dr. Bogbath gave us a very good overview of some of the things that could be happening, some of the things that could cause infertility. I guess when folks are going in for evaluations, like what are some of the tests, procedures? How do you try to figure out what is causing someone's fertility challenges? You're muted.
Okay, again, excellent question. I keep coming back to that same theme of you need the sperm, you need the egg, and you need a place for them to meet and then finally decide. So for the egg, for the sperm, it's actually very easy. It's always been the same, which is you get the semen, look under the microscope, and you can actually count the number of sperm, see how fast they're moving, what's the volume of the semen. There are very defined parameters that get updated by the WHO on a regular basis because things are changing all the time. From 1950 to now, there's a dramatic drop in the volume, the sperm count, as well as the motility. And so what was normal in 1950 or what was abnormal in 1950 today is normal because worldwide there is a big drop. That's a little interesting fact there. From the female perspective, we don't have ability to do an egg analysis per se under the microscope. Yes, we do when we do IVF, but that doesn't really give account for how many there are in the ovary itself. So we have some indirect ways of documenting that. And anytime you look at something indirectly, you have to look at it in more than one way to understand that. So the classic method is on the third day of the menstrual cycle, checking the hormone FSH and estradiol. The FSH should be less than 10 and estradiol should be less than 50. That has since slowly gone out of vogue because it's not if it is in the normal range, it's reassuring, but it doesn't guarantee that it is actually good, the ovarian reserve. So you could have a normal value, but still the person could have decreased ovarian reserve. So that realization resulted in further exploration, and we now have more robust methods. One is another hormone called anti-Mullerian hormone. That's a blood test as well. So if it is low, then it signifies a low ovarian reserve, and normal is more than 2. In addition to that, looking at the ovary on the second, third, or fourth day of the menstrual cycle, you can count small follicles called antral follicles with ultrasound, and you should have about 12 total. It doesn't matter exactly how many in one ovary, but if you add the 2 together, it should be 12 or more, and that is reassuring. And the more closer it gets to 0, the more concerning that is, as the ovarian reserve is low in that scenario. In terms of the fallopian tube, we either inject a dye or water and measure that the dye or water is able to flow freely from the uterine side into the pelvic cavity. And that is either a hysterosalpingogram or a saline sonogram. So one involves X-ray, the other one involves ultrasound to document. And finally, you want to make sure that the cavity is in no way affected. The hysterosalpingogram and saline sonogram again can delineate that because first the fluid of the dye has to go through the uterine cavity before it goes into the tubes. So by documenting that and evaluating whether it is the normal inverted triangular shape or whether it is actually divided, whether there are any defects in that inverted triangular shape, gives us an idea as to what's happening inside the uterine cavity. These are the standard tests, right? I mean, this is like, but based on stuff that you find, then you order other. For example, you suspect a developmental anomaly, and you may order an MRI to further document it, or a 3-dimensional ultrasound to further document that. If you find some problem with the fallopian tube, we may decide to do a laparoscopy to directly look at the tube and not only evaluate what's going on, but possibly fix the problem as well. Again, with the ovary, if you have polycystic ovary syndrome, then you may order some more other blood tests to document what's going on. The same thing with the sperm. There may be ultrasound of the prostate. There may be ultrasound of the scrotum and the testes. There could be hormonal test that we order based on the initial test that we ordered that further lead to other investigations.
I can imagine this next question is going to be sort of just as big as the previous. I'm hoping you can give us another high level summary or even just a little sense of once you have either figured out what's causing someone's infertility or have made the decision to pursue treatments, what kinds of options for treatment are available? And can you maybe run through them from a like low intervention to high intervention scale?
Okay. I can cut to the chase here and give you a really overview because we used to do a lot of things in the past that have all been sort of disproven. For example, people have unexplained infertility, just go home, here's some Clomid to try and get more eggs to come out and you can have sex at home. We now know that unless they have an ovulation like PCOS, where the egg is not coming out or being released, and you give them tablets and have sex at home, that works. But in an unexplained infertility patient, that doesn't work. So the current thinking is, if the sperm count is normal, the tube is open, and the person, whether they're releasing egg or not, it doesn't matter because if they're not releasing egg, we're going to give tablets to release egg. It is doing ovarian stimulation, that is the term, ovarian stimulation, with intrauterine insemination, where we take the sperm, concentrate it, put it inside the uterus. Even if the sperm count is absolutely normal, that seems to improve the chance of success any given month. Mind you, these are patients who have at least been trying for 6 months if they're over 35, and a year if they are under 35. So they are having trouble achieving the pregnancy. So this improves that quite significantly over first 3 months. From 4th month to the 6th month, if they're not pregnant in the first 3 attempts, the chances go down. It's not incredibly low, but it is low enough that we say you now have a dichotomy of path. There's a divergence. You can choose to do 3 months of ovarian stimulation and IUI, or move on to IVF. Okay. If there's a problem with the fallopian tube, it's closed, then obviously if we cannot fix that, if we cannot open it, then it's IVF because you need to bypass the tube. If there is a severe problem with the sperm that is that cannot be improved with medication or hormones, again, we have to do IVF because IVF overcomes that or helps to overcome that. Okay, so that is ultimately the path. Either you go straight to IVF because your fallopian tube is closed or your sperm count is that low, or you do the ovarian stimulation and IUI, and if unsuccessful, finally come back to the IVF anyway. So that's really, it has become very simple now in terms of treatment. Of course, how to get there, as I explained, fallopian tube, maybe you can fix it. Sperm count, maybe you can fix it. There are, the treatment is not a simple IUI or IVF. It's a final path, but to get there, you have a lot of little treatments based on exactly what the problem is and whether it can be fixed.
Thank you. So we've been talking a lot about the physical aspects so far. And Dr. Zweifel, I'd like to hear a little bit from your perspective. What kinds of emotional and mental health supports are either available or recommended when people are experiencing fertility treatments?
So I think there's different levels of care that are available. So individual psychotherapy, so meeting with a mental health provider. I think it's definitely helpful if that mental health provider has some awareness, some understanding of fertility treatments. There are not that many that are going to have tremendous knowledge, though. But I would still say a mental health provider in general is going to be helpful to help folks develop better communication, be able to understand their own emotional experiences, be able to suggest some things in terms of self-care. So I would say individual psychotherapy and / or couples therapy. I will say I've got a lot of couples who let me rephrase that. I've got a number of times where I'm seeing one person, and from time to time, the partner will come and join a session. I always tell whoever the main patient is, I'm like, you can bring in whoever you want, anytime you want. And so a lot of times that partner will pop in. And those sessions often focus on trying to help there be better communication about how just to be supportive. So what I will say is, particularly when you see a heterosexual couple, guys tend to fall into some pretty common responses in terms of trying to be supportive. I would argue that these are things that our culture socializes in boys, which is to be a problem solver. And I always like to say, it's not that women don't like to solve problems, but guys really, really hate problems they can't solve. And infertility is a problem that they can't just solve. And so a lot of times what happens with that is when a guy has a problem he can't solve, and the real problem for him is seeing his wife in distress, that she is so distressed and he can't solve the source of her distress. He'll sometimes try to reframe things and say, well, maybe it's not a problem. Like, everything's okay. And because if he can talk her out of being upset, then he doesn't have a problem he can't solve. So there's that. And there's also this feeling like being a cheerleader for his wife. Like, it's going to be okay. Let's just go out and do this. Let's go out and do that, blah, 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 blah. And I think that those are super well-intended efforts, like absolutely well-intended. But a lot of times they just miss the mark. So one of the common things that I'll say to couples, and I will use frank language here, I'll say, you know what could be the best thing sometimes? It's just have her, sit down on the couch, pat the spot next to you, say, come here, sit down. And she does, and you just say, you know what, this just sucks. I swear to God, it's like, and she's probably going to start crying. And that's okay, because she will cry and eventually she'll run out of steam. And she's going to feel unheard. She's going to feel like there was space to hear her emotions. And I think she's going to feel like she's got a teammate who could tolerate those emotions. And I think it actually brings people together just to say things candidly about that. So, individual therapy, couples therapy. I will say, I think sometimes some of the best support, I think Jamie references, is finding others who are going through the same darn thing. Sometimes, I don't know if I want to say the word lucky, but sometimes you're fortunate to know somebody who's going through infertility. If lucky feels like the wrong word to use there. But so if you just come across somebody in your environment who gets it, that can be really helpful. But a lot of times what you're gonna have to do is reach out. And what I don't think this is gonna be a surprise to anybody, online support groups are more prevalent and more available than in-person support groups. There are some in-person support groups, but I think the online ones tend to be easier to attend. And I think it was Stacy who mentioned she liked the anonymity of things. So I think support groups, I will also say podcasts. People feel like they get a lot of information out of podcasts. And so everything that Bhagavath was talking about, if you hear it over and over again, you hear somebody else use this, like they're saying the same thing, but they're using different words. So that helps you feel more grounded and understanding your care, but also just hearing about other people's experiences, I think normalizes things. It's not just a you thing. So I think reaching out and using those resources. I'll also say, honestly, there's really good books out there. And there's books that are, more informational. And then there's books that are, people's personal experiences. And there's even books that the writers who have a history of infertility, they're kind of comedy. they're finding a way to find some humor in the experience. So I think all those sorts of things, I think telling family can be great, telling family and friends, but I think that needs to be a well thought out decision, understanding who those folks are. I think sometimes the downside of bringing family into things is they might be so invested in it for you that they're asking too many follow-up questions. And you feel like every little twist and turn you've got a whole bunch of people you have to inform about, okay, now this happened. And it gets to be burdensome. And I will say in regards to that, if somebody runs into it, one of the things I'm often suggesting is figure out a point person who you can communicate with, and then that person's in charge of informing others. They just offload that. And there's probably somebody in your life who wants to be helpful, and now you're actually giving them a way to be helpful. So anyway, lots of different types of resources, and I think probably a collection of those, and leaning on sometimes more one than the other. Does that answer your question, Jackie?
Absolutely. And I'd also like to hear from maybe Jamie and then Stacy. What kind of support did you find helpful throughout your experiences?
Sure. So I wrote this down. I came prepared because I did them all. And again, these are just things I did personally, so not necessarily endorsed here, but I was a big Resolve support group person. So in Wisconsin, there's a Resolve Facebook support group page, and we actually had in-person meetings while I was going through this before COVID. I think this was in the Milwaukee area. So that you matched up from the Resolve website. And so I did that actually for a few years, and I met some of my best friends still today, and we all went through it together. So that was really nice. Again, COVID kind of threw a wrench in some of it, but that's a good option. I also was part of multiple Facebook groups. So depending on your diagnosis, some specialize more in those areas than others. So you can get real, maybe good and bad information, take it with a grain of salt, ask your doctor, but I learned a lot. There's also some really good Instagram accounts, especially in the third-party reproduction space with donor eggs, sperm donor, gestational carriers, those sort of things. I also did try a few therapists, and I second Dr. Zweifel's opinion to try to find someone that has more background in this. I was not successful when I was looking in the Milwaukee area, and it did not work out well for me. Dr. Zweifels on the call, maybe get on her list and not someone else's that you just find. I also read some books. One of the books I first read, given that I had egg issues, was It Starts with the Egg. I think that's a pretty standard one, maybe even updated now. I also read 3 Makes Baby, which is very popular in the donor conceived parenthood world. Let's see, I listened to podcasts. I listened to Beat in Fertility for years. I was actually a guest on that podcast after I had my child as a success story. And that's how I found my doctor, actually, who helped my 3rd or my 4th doctor that helped me actually have our babies. So she was great. And then my last resource that I used kind of when I went through 3 different clinics and 3 doctors to kind of search where I wanted to go was Fertility IQ. They have doctor reviews. And then they also have a place that says what companies have insurance. It's not exhaustive, but that was an important resource too. So I think that's everything. I probably went to many more websites than this even and did more, but that is my somewhat exhaustive list of all the things I went through in 7 years to try and get these babies here. So.
While I wasn't as prepared as Jamie writing a whole list, I did write a little bit of what helped me. And, as I mentioned before, what wasn't helping was the friends I was around at the time. So really digging in and just having other conversations with new people. And I found over half of the coworkers I worked with were going through some sort of infertility or fertility treatments or did. So the more I talked about it, the more I realized there was so many people out there, and I just couldn't believe how many people were going through it. It shocked me. It was a little nerve-wracking. Like I said before, I liked to be a little more confidential, but the more I just was like, yeah, we're going through this, and I felt comfortable talking to one person at a time. When they shared their experience, it was like, okay, I can talk to you now. So I had kind of this cohort of coworkers, branched out some of my friends that maybe lived across states. So we did messaging. Maybe it was a middle of the night of, oh, I'm struggling tonight, and just kind of sharing experiences back and forth. And we kind of had this agreement that we could use each other for that. So just like, yeah, again, kind of using that community, talking about it, not being super shy about not talking about it. venting, sharing struggles, all that stuff. And then of course the Google searches and the online communities. And I was a little more hesitant to join them. I didn't actually join any. I read a lot of people's conversations that were similar to mine, and that seemed to help just kind of, again, oh, you're going through that too kind of mentality. And then a couple books. So one book that was shared, it wasn't really about the content of the book. It was, again, more of that community passing around from person to person who's having this similar experience. Hey, maybe try this. And it was called The Infertility Cure. And it was really just about, you know, changing diet, doing different lifestyle changes, that sort of thing, which of course, you know, we all tried that first. You know, months of diet changing and no dairy, no sugar, no all this stuff, you know, and it still didn't work. But it just seemed like there was an added something and like something I could do. So that was something that was a little helpful, where I wasn't just waiting for whatever, you know, I could actually do something. And then another thing that I could do was my friend, actually, a really good friend of mine who stood up in my wedding, wrote a book as well called let me pull it, Manifesting Baby. And it's a journal where I just wrote one day for 30 days, and she kind of like leads you through kind of just thinking about manifesting your babies. So that was kind of just a fun little way of getting through 1 month and having hope. And that was one of the things that I think I lost a lot through. So anything that could give me hope that I'm working towards something, like Dr. Zweifel said, you know, even my husband felt helpless. I felt even more helpless, almost, I think, just because I couldn't carry his baby. And we didn't know why. We didn't have that reason. We were that unexplained 10% or whatever. And so anything I could do to just try something new did help me, and just having that community to talk about it.
Thank you both so much. We just heard a ton of resources. We're taking notes as a moderator team. So everyone who's listening, I know that was a lot to write down. Don't worry, we will get links out after this talk is over a little bit later this week. We are kind of launching into the end portion of our prepared panel, and then we'll jump into a few questions that have come in via the Q&A. I want to start with a question for Dr. Bhagavath. Do we know on average how long people or couples spend getting fertility care? How long does this journey take for people? You are muted.
That's a very difficult question to answer, because there are the lucky couples who the first month of treatment get pregnant, and then there are couples who have spent 3 years or more in the journey and they're still nowhere near the end. So it is a wide varying duration. But on the whole, I would say the vast majority would, within the first year of starting treatment, would have achieved their pregnancy and moved on to an ongoing pregnancy. And that's a reasonable approximation of how long it takes. But when it goes beyond the first year, definitely there are challenges that are being worked through.
One of the reasons we wanted to ask a little bit about, how long on average folks spend receiving treatment was also thinking about, on average, the cost of treatments. And, in preparing for this talk, I spent some time trying to research, average cost that people would spend on fertility treatments. And it's truly hard to say because it can widely vary from treatment to treatment and from state to state, whether there's coverage in that state or not. But one thing that was very clear to me is that the cost of fertility care can be an enormous barrier for a lot of people and involve a lot of strategy and challenge and just trying to fill in gaps. I want to ask this question for our patient panelists. We'll start maybe with Stacy this time and then Jamie. How did you navigate the financial considerations of pursuing fertility care, which sounds like a very challenging and complex problem?
Yeah, I worked for the state, so I only had 2 options for healthcare at that time, and I wasn't in the place to look for another job that might do better. So I kind of made the decision. We made the decision to just kind of decide. And one of the health we did some research. So one covered 50% of some infertility treatment, and one didn't cover anything, but there was some sort of sliding scale and things like that. So, and then it's also looking into, and I should disclose I was in Colorado at the time. My first was born in Colorado, and we ended up choosing the first option for a while to do the IUIs, and it ended up being about $1,000 anyway, each IUI treatment. So we did the 3 months, and those didn't work. Again, no, not sure why not, like unexplained. So we decided to just move forward to the IVF because it didn't cover. We just took the financing. We switched insurances and took the finance option to do through the healthcare provider. It was one of the best in Colorado, so we decided for provider and success rate option versus cost, unfortunately. So I think overall it was about $30,000 in total, with like the $5,000 of medications. You have to pump the hormones and all the things that Jamie was talking about, changes you physically and mentally. And let me tell you about the husband relationship dynamic there too, when hormones are pumping. And that's a whole nother day, I'm sure, of storytelling. But thinking about, do we want to go for, okay, it's a $23,000, but then you're also having to figure out all these medications and how much they're going to cost and how many do you have to do. And then for our second, we did the frozen embryo transfer. We were one of the lucky ones that we got, after all the chromosome testing and everything, we had 5 viable embryos. So we have 3 left, frozen still in Colorado, and we fly back to Colorado when we want to have another kid and get the FET done. So, but each one of those, so for our second, was about $5,000 in total that we had to save and do that, which was the cheaper option than trying to get them flown here. So it was just kind of doing the research back and forth and figuring out, it's about the same cost for some of the things, depending, whatever you choose. I probably could have done more research, and Jamie, I think, with some of her options, has a lot more to share with that. So I just went more of the, here's what I'm being told, here are my options, without really changing my life fully as far as job goes and lifestyle.
So I am one of the lucky few in the state to have insurance coverage for all of this, or I definitely would not have my children. So over the course of 2 children, I had 3 egg retrievals and 7 transfers. Luckily, my insurance first had a 15,000 out of max limit, hit that. And then the next year they changed to doing, for anyone familiar, Progeny, they have smart cycles, and it covered a little more. Even still, donors aren't covered. So I estimate, and I should have kept track, I'm kind of glad I didn't, but we probably spent somewhere between 50 and 60 at least for all of this, $1,000. Though I estimate the services with my high needs for medication and all those, probably 150 to 200,000 that would have been out of pocket. So that's crazy, I know, but I'm just telling to you real. And that's why I go back to, you may need to look for a job with insurance coverage if that's an option. I have had people that I know that have worked at Starbucks. I have people that have switched their jobs to over the border in Illinois because they have a mandate. So some insurances covered it down there. So I know people that have moved or changed jobs because of the costs I just quoted. So it's just not fair, right? So that's part of the reason I'm here. And I think we're going to talk about the Building Families Alliance, but that is why whenever they say, do you want to help get infertility coverage passed in Wisconsin? I say, absolutely, because I know people that the financial part was worse than all the other parts, unfortunately, and that they don't have their baby or babies here to make their tens of thousands or more worth it. So yeah, so that's kind of the straight numbers for me. I'm sure the doctors can probably agree or not, but that's, some people paid that type of money. And so, yeah, not good here. So
that brings me to a follow-up I have for Dr. Bhagavath. So before coming to Wisconsin, you've been here about 3 years. You practiced in a state that did have some sort of state mandated insurance coverage. I am curious if you've seen, in your time in Wisconsin, if you've seen those financial considerations affect how your patients are making treatment choices.
Thank you. I want to assure Jamie that almost all of those doctors are acutely aware of how much it costs. Believe it or not, perhaps less aware when I was in Rhode Island, and that's where I started. And Rhode Island, it was a mandated state, just like Illinois. And as a result, it was 100% covered. So I practiced medicine as I would, like what does the patient need, and order whatever she needed. Then I moved to New York, where until I left, in fact, 5 days before I left New York, that became a mandated state as well. But until that time, it was partially mandated. What it was is up to IVF was covered, but not beyond. And I started seeing some effects of that. Patients would do 15 cycles of IUI when statistics was very clear that after the sixth cycle, it's really you're looking for a miracle. But because it was covered and there was not a cap on it, they would keep on doing IUIs. But the vast majority would move on, and I did observe there are some patients who would stop. Unfortunately, they just couldn't financially bear that cost. And then there are others who would do mortgaging of their house, second mortgaging of their house and stuff.
You went mute again, Dr. Baklava.
How did that happen? So I don't know where I lost you guys, but it was definitely distressing in New York for the few patients where I could see that either they would stop treatment or they would go into financial difficulties to continue the treatment process. Then I moved to Wisconsin, and oh my God, it was really tough because everything, even IUI, was practiced in a very different way. And I had to really sit down and talk with my partners to understand how they are navigating the difficulty, because I was not used to it at all. And that was one of the reasons why I teamed up with Maria and Melody and others to start the Building Families Alliance, because I felt the acute need for the patients of Wisconsin.
Tell us more, if you can, about the Building Families Alliance and what's being done right now in Wisconsin to advocate for more coverage for fertility care.
It looks like Jamie has a very good grasp of it as well, and Dr. Zweifel has been on this journey with me from the very beginning. It was a chance meeting at the Resolve Day in 2020 with the pandemic. We were all doing virtual advocacy. I met with Maria Novotny, and I saw her passion. She's a patient herself and then advocate, and she has been doing this for 10 years. And I, coming from states that had coverage, never involved myself in advocacy this way. So I saw the opportunity and the need. And so we got together, a big group of people. We contacted all the doctors in the state of Wisconsin that provide infertility coverage, and got them on board. And we started. The express purpose of this is to get the state to recognize the need for coverage, so they can mandate that all Wisconsinites will have access to fertility treatment as long as they have insurance coverage. So that was the goal, and that still remains the goal. And I think in the last 3 years, we've come a long way. I have to recognize Sarah Finger, who has been, she is somebody who knows the political scene here. She came on board from the very first meeting, and she has been an amazing resource and got us to where we are now, where we have introduced the bill once. We are now looking at the reintroduction of the bill, but politically we have stopped because Governor Evers has included a line item in the budget this time for including fertility coverage. So if that works, then the effort needed. So let's see where that goes. But if that is not successful and the budget is passed without that item being passed, then we have the bill ready to be reintroduced again in the fall. So a lot of work has undergone in this process. The support of the patients, the Building Families Alliance has a big support group of patients who signed in, and so their advocacy, anytime we are introducing something, to go talk to their write emails or letters to their representatives is very, very powerful and very necessary to keep pushing on this goal.
I know we have a lot of questions that have come in that we want to get to, but before we jump into audience questions, I think all of our panelists are all involved in the Building Families Alliance. If you want to say just a couple words about what that experience has been like, kind of why you wanted to be part of it and what kinds of things you get to participate in as part of the Alliance. Feel free to share a little bit if you'd like, and then we can jump into some audience questions.
Well, I'm a part of it because I'm a part of this clinic. Bhagavat brought it up to me. He said, "Hey, you should be a part of this." So that's why I'm part of it. But I mean, it's important to be there. I mean, these are our people that are struggling, and so it's important to help them in all the ways that we can. So that's why I'm a part of it.
I'm a part of it. I did the advocacy day now 2 years ago, the federal one, and that was a great experience to meet, share the story. I'm very happy there's something in Wisconsin specifically, because the federal advocacy is great and needed, but the states vary so much on what's mandated. So the fact that there's something in Wisconsin, is awesome. I think I'm a lifelong Wisconsinite, and most people I know are too, and people wouldn't want to move for this sort of thing. So we shouldn't have to move. So hopefully Wisconsin can pass this, because it just needed, as you guys can hear by the stats. So I'll be watching the budget meetings for the state, I guess.
Yeah, and I'm new. I just joined recently, and this was an opportunity where I was, asked. So, one of the things is to speak at an event like this, share your story, which I think is amazing. But I hope to get involved more. I think my mom shared it with me, actually. She messaged me on Facebook Messenger and said, "You should be involved in this." And I clicked on the link and did. So it was a great, she has more time being retired to research things, and I didn't even know this existed. So I was happy to be involved.
Awesome.
And I should give a quick shout out to our current chair, who's really moving mountains, Maria Rameke-Klaas, who has really done an amazing job of moving the agenda forward at a breakneck speed. And I think this Infertility Awareness Week this year, compared to the other years, is the best ever, with the highest publicity, and also the number of different programs we are having, this being one of them, is really astounding. And I'm really grateful for her work.
Yeah, we wanted to have this community talk a couple weeks in advance of National Infertility Awareness Week, which will be April 23rd through the 29th this year. So we're just about 2 weeks out. Lots of folks took the opportunity during the registration to sign up for more information from the Building Families Alliance. So, and Melody just shared a link in the chat as well. If you want to learn more, you can sign up there. So we're very excited to be able to help build that base, build that foundation as we work towards better access and better coverage around the state. Also, I want to thank everyone for your questions that have come in. I can lead off with, I will lead off with a question from Emily. Do consumer level fertility testing kits for sperm or for hormones or et cetera have merit, or are they just preying on people in difficult situations? How do you feel about mail order fertility testing kits?
Technology has really come far. I cannot say that they are totally preying on people, but like any test, you need some knowledge to interpret it and then figure out what's the next step. So, for example, this semen analysis, even when you do semen analyses, we require that it be done in a fertility clinic because there are details in it that even, for example, a hospital-based semen analyses doesn't have some details, for example, the morphology. And if they do have the detail, it could be the old standard and not the new standard. So there are nuances and there's always more details there. But if you want a quick and dirty, do I even have sperm or not? Is this a problem? Then a semen analysis that's ordered through the internet can be helpful. So I wouldn't say that it is preying on, but to an extent, for the money you spend, is this going to help you further? Ultimately, you may still need to, if you're doing this testing because you're concerned you are past that 1 year or 6 month mark based on your age, then ultimately you still need to come to a clinic, and the clinic is not going to depend on these commercial online ordering tests. We are going to look for more standardized testing, unfortunately. So you will end up paying again for that. So that is my take on that. I would not say that they are fraud or they are useless, but how useful it will be when you really need that to inform the treatment that needs to be designed is questionable.
Another participant submitted question: can a pap smear tell you about challenges with fertility?
Not really. If they saw sperm that's moving, which you won't, the only thing I can think of where it can help is in the old days, we used to do what's called postcoital testing. The woman would come in after sex and we'll take the cervical mucus and look under the microscope to see if there is moving sperm in there. That test has subsequently been found to be not very useful, and we stopped doing that. So a pap smear randomly done is not going to in any way help with fertility. The reason pap smear is always asked for, and we want to know what's the most recent pap smear, is we don't want to help someone get pregnant only to find that when they are 12 weeks or 16 weeks pregnant, they have a serious problem with their cervix that needs treatment, and then we have to interrupt the pregnancy. That is the reason why pap smear is always asked, in case the question is stemming from that. I want to explain, because time and again we have come across that, and then we go, oh gosh, we help them achieve this very sought after pregnancy, and now that pregnancy is in jeopardy because it's a question of which is more important, prioritization.
We're getting a lot of sort of questions that I think Dr. Bhagwat will field for us. Do a certain percentage of IVF patients go on to see a reproductive immunologist? And how closely do reproductive immunologists work with fertility clinics here?
Yes, there's a small percentage, not necessarily IVF alone, but it's patients who get pregnant and lose the pregnancy repeatedly. Those are the patients who get referred to reproductive immunology if our standard testing is not able to identify the problem. So we do work with a clinic in Chicago. So my partner, Dr. Stanich Kostic, is a researcher in this space. So we first refer our patients to him, and then he, after his evaluation, if he feels, he would refer the patients to Chicago.
We had kind of a related question come in the registration leading up to the event. What if someone has had a couple recurrent miscarriages with like no heartbeat detected early on in pregnancy? What kinds of questions or tests should they ask for with their fertility doctors?
If these are miscarriages without a heartbeat, so the most likely cause for that is a chromosomal abnormality in the embryo. Once there is miscarriage after heartbeat, then we start worrying about factors that could lead to recurrent pregnancy losses. So again, it's a complex thing. Age is an important factor. The older you are, the greater the chance there can be chromosomally abnormal embryos. So the question, really, there's not much of a question to ask. It is when you have that miscarriage, before you see the fertility doctor, to ask your OB/GYN, can you perform a chromosomal analysis on this miscarriage so I can know what it is? Because that's often the problem we face. Patients would come to us, they would have had repeated miscarriages without heartbeat, with heartbeat, but we have no chromosomal analyses. It's too late to do them after that. So that's the question would be to your general OB/GYN who's managing these miscarriages to see, could you please do the chromosomal testing on these products of conception?
Is having a very short light period indicative of a fertility problem? Is that something to be concerned about?
Not really. Different people have different types of, heaviness of the period. If you're not having one period a month on an average, that is cause for concern. Up to 9 or as low as 9 menses a year is okay, it's still considered normal. 8 or less menses a year is considered abnormal. But that means you have longer duration between menses when that happens. So that is abnormal, and that's definitely a cause for concern. But lighter, unless they are like just spotting or very light for just one day, in that scenario, perhaps there has been some DNC in the past, some other sort of trauma to the uterine cavity that is causing that and requires evaluation.
We've got one more question. For someone who's younger, wants a family, but's not ready to try for a couple of years, maybe we're in our early 30s or so, is there anything they can do to understand their fertility or potential infertility before trying? So any tests to look for, or any advice that you have for people who know that they want to pursue family later, but not totally ready for it right now? What do we need to know about our fertility?
You're muted again.
Sorry, I keep forgetting to turn that on. Fertility is a direct is directly related to women's age, unfortunately. The older the woman, the lower the chance of fertility. And 35 is an arbitrarily drawn cutoff. Many women think, I'm going to turn 35 next month and it's going to change. It's not true. It's a continuum, unfortunately. And even there, different women, there are women who are 30 who are having trouble, and their response, ovarian response, is more like a 35-year-old. And then there are 40-year-olds who would have a response that's like a 35-year-old. So there is a variation there as well. So the older you are, the more concerned you should be. And certainly after the age of 35, if you're still considering a delay of childbearing, that's the time to see a fertility doctor to talk about what can I do to preserve my fertility. I'm not ready for another 3 years. I'm not ready until I'm 40. This is how my career trajectory or my personal circumstance is. And in that scenario, what can I do to maintain my fertility and not face trouble at that time when I am ready? So that's where the egg cryopreservation comes in. And that could be a conversation that you should be having with a fertility specialist. But if you are Younger than 35, again, it's a question of how large is the family that you desire. If you want to have a family of 4 and you're now 31, 32, you are now looking at being beyond the age of 35 when you're still completing your family. So, unless you're going to get pregnant and deliver every year, it's unlikely that you will have that family of 4 before the age of 35, 36. So again, you have to think through how big is this family that I want? How often do I think that I will be able to get pregnant and have babies, considering finance, personal circumstances, career, etc. So it's not just a simple question of age. But for those who want to know, hey, am I ovulating regularly? I don't know if I'm ovulating regularly. You can buy over-the-counter ovulation predictor kits, which are cheap. Most of them are fairly robust today. Again, technology has advanced so much. It's not like one is way better than the other. So we have our own certain biases as doctors. So we'll recommend one particular company or the other. I don't want to say that here. But definitely, you can just buy any one of these ovulation predictor kits and follow the directions to see if you're ovulating, if you're concerned that you're ovulating, if that's what you want to know. On the other hand, even couples who are not having any infertility, but they're starting on the journey, it's certainly, instead of guessing when you're ovulating, using the ovulation predictor kit helps you determine when you're ovulating and therefore have sex around that time. The only concern I have with that is suddenly now what is a routine, normal, pleasurable activity becomes an anxiety-provoking because you're now constantly watching your urine test, and then you're trying to have sex at a time that probably not ready to have sex. So there is some caveat or downside to doing that. But for that person who wants to have the control and wants to know, this is certainly an easy, no prescription needed strategy to follow.
All right, I think we have reached the end of our submitted questions. Hopefully Melody and Cheryl will let me know if I've missed any. And I think we might be approaching the end of our time together tonight. Do any of the panelists have any final thoughts or recommendations that you'd like to share with our guests, with the folks who joined us this evening?
I'm just hoping that you recognize you're not alone. You heard a lot of voices of support. So I'm hoping that you're feeling supported.
Don't lose the hope. That's my thought.
I would say,
I wanted to second that somebody had mentioned, oh, just stop trying, have a glass of wine, relax. And when you want it so bad, there's not a day that you can't just not think about wanting it. So that's okay. But I think when you start losing the hope, and that's where, it might not happen. So you gotta keep it going. Hopefully, I don't know if that's helpful or not either.
I would say, don't give up, realizing that there are limits to what people want to go through physically, mentally, financially, but being on the other side, though I don't know if it's ever really over for you. It's worth it. I will say everything I went through, even the hard stuff, still it's worth it. So try to keep going if you can and find a way.
I echo all of that. My personal message to the viewers of Wisconsin is fight for your rights. You should have the ability to have fertility coverage, and it is absolutely unacceptable that even the basic coverage is denied in the state. That is appalling in 2023. So we are here, we are fighting for you. Join us in the fight.
Thank you so much to each of our panelists. Your insights, your thoughts, your stories were invaluable for us tonight. I am personally so deeply grateful for your time. And it was a real pleasure to get to speak with you for this last almost hour and a half. Let's see some clap reactions. Let's give it up for our incredible panelists. And also, thank you so much to everyone who tuned in with us. It was a gorgeous day. It was a gorgeous like night to go outside and do things, and really appreciate that you gave your time and attention to us here. If you think of further questions or anything, I think my contact information was in the Zoom invite, and you will get a follow-up message that has resources folks shared, links to the Building Families Alliance, just more information about everything that we talked about this evening. Feel free to send extra questions and we can help direct you to resources and connect you to some information around the state. And truly, thank you everyone so much. So I hope everyone can take some time over the next several days to enjoy unseasonable but gorgeous weather. Go outside, get a little walk in. Take care, and thank you all so much for spending this time with us tonight.